Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium. And today I'm talking with Dr. Neil Kalman, uh, an old friend and colleague. We've danced together, we've sung together, and he's played harmonica and uh, impressed me. At any rate, Dr. Kalman is President and CEO of the Institute for Family Health and System Chair of Family Health and Community Health at the Icahn School of Medicine at Mount Sinai. Neil, thank you so much for joining with me today.
Sure, good to see you, Larry. It's been a while.
It has been a while.
Yeah.
It has been a while. So your institute is, in my way of thinking, one of the most remarkable accomplishments over the course of your career. I've watched as you started small and you've grown, and you play a special role in the New York City area, metropolitan area. And I'm wondering, could you start off, Neil, by describing your organization so that people can see what you've got going?
Yeah, sure. We started, in 1985. So it's about 35 years ago. And this had a vision of doing family medicine for underserved communities. And so we now have 34 locations in New York City and up the Hudson Valley, even a remote rural location in Western Ulster County. So we're doing both urban and some rural healthcare. And at the meantime, we sort of committed ourselves to not being just a consumer of family docs, but a producer. So we have 3 family medicine residency programs with a total of about, 80 something family docs, 4 fellowship programs, nurse practitioner residency program, and we're just doing what we do. We've done a lot of development in the behavioral health area. So about a quarter of all of our visits are to behavioral health providers. And last year we did about 650,000 visits. Family medicine is about 70% of that, and the rest is oral health. I think we have now 54 dental chairs across the system, and lots of behavioral health. So, we're just doing what we dreamed of doing, training people and lots of students. Our affiliation with Mount Sinai started in 2012. We were dedicated to taking another school off the I don't know, whatever you call it, target list or orphan
Target
list
school
or
list,
whatever.
yes.
I worked on doing that with some folks at Einstein years ago and figured, it was time that we did it at Sinai. And they were very receptive because we were opening a huge practice about 10 blocks away, and they wanted to be affiliated with it. So we said, then you got to have a department. And they said, okay, then you got to be chair. So that's, so our whole institute is now affiliated with Sinai. And it's been an amazing experience to, be inside a medical school for the first time really in our existence, and to have an opportunity to do so much training of medical students and stuff. And we're also training students from, we take rotations from people all over the country, and we're training students now from Sophie Davis Medical School. In our rural area, we're training people from Touro College of Osteopathic Medicine. And it's, and it still was fun up until March I think it was, sometime in March, this thing sort of happened, and it was really fun up until then. And then kind of the world came crashing down. There's nothing that supports ambulatory care more than having the governors say nobody should leave their home, and especially to go to the doctor, unless you were urgently ill. And so, we converted over to telehealth. Literally within 3 days, we were operating on a telehealth platform. We've been, as you know, I've been very interested in health information technology. And so we've been on the Epic system at the Institute since 2002. So we were really prepped for being able to flip right over to telehealth. And we within about a week, we were doing close to 2,000 telehealth visits a day. And so a lot of experience with that. And yeah, I don't think we're ever going to go back to where we were. I think the world has changed.
I would absolutely agree with you. And so tell me a little bit more. You would, before we started recording, you were telling me about some financial decisions that were impacting your organization. Could you share that with folks?
Yeah, I mean, the there's a couple of misconceptions about telehealth. The first is that you don't need any support staff. Hey, the doctor just gets on the phone with the patient, and what more do you need? So you should be saving money on all this support staff and everything. And the second is you don't need any facilities because people aren't going to work, and what people forgot, the funders forgot that we're still paying rent on those facilities. We still had 1,400 employees that we were supporting, them and their families. And it was a huge shock when the people at the health department decided that a telehealth visit wasn't worth as much in terms of reimbursement as a face-to-face visit, and so they started paying really badly for telehealth visits. Interestingly, the Office of Mental Health in New York, like, almost instantly said, wow, we're, whether you talk to your patients by phone or video or see them in person, we're paying you the same amount. You're doing the same thing for them, and we're paying you the same amount. So we had this dichotomous sort of system. And of course, dental closed completely. The American Dental Association, recognized that dentistry was a very high risk procedure with aerosolized infections and things. That went down, almost immediately. And so, we started burning through money. We laid off about, I think at our peak, about 220 support staff. But the support staff were there, and they were booking appointments for people. They were answering phones. They were managing our call center. They were doing all the things that they were doing before, except not doing blood pressures and, immunizations and stuff. Nurses were counseling people over the phone. It took a while to organize a system around telehealth with appointments and everything. And, we were using Epic. We were using the DoxyMe platform for the telehealth visits, which, turned out to be quite useful. Readily available to us. So, now we're in the process of sort of getting back. But overall, during that time period, we lost about $5 million. And we're still losing money. Most of the losses so far, almost all the losses, have been made by the stimulus funds. The quite reasonable in relationship to stimulus funds going to community health centers. However, no stimulus so far in the month of September, and July, where there was the last sort of bolus of stimulus money, we still lost $600,000. And so we're really looking at a point where a lot of patients are still not comfortable coming back in person. The behavioral health people don't really come back. The providers aren't anxious to come back. They're seeing the same number of patients, and they're doing all the work at home. And we're hoping that the Office of Mental of the health services we provide. Dentistry is coming back slowly with lots of, some time to cleanse the rooms in between, and, additional expenses for air purifiers, things like that in every operatory. And the face-to-face visits for medical, about 60% right now, and we're going to get them up around 80%. Of course, we have to keep social distance. So that means, some inefficiencies of scheduling people. And we're pushing people pretty hard. It's a very stressful time to be in family medicine. People are jumping back and forth between video visits and in-person visits, and patients are struggling. They don't know if they want to come back or they don't want to come back. We're trying to figure out, which people really need to come back. We're trying to catch up on immunizations. All of the quality metrics that we were so proud of, that we tracked all the time, have gone down the tubes because, we haven't been able to get people eye exams, and their A1Cs aren't all been controlled. And, that it's been a struggle. And so a lot of stress in the organization, financial stress. We literally built up and covered a 36-bed inpatient unit at Mount Sinai single-handedly with the family practice residents and faculty, which was absolutely amazing. We run an 18-bed unit all the time, but we doubled. For 2 months during the pandemic, it was 100% COVID patients, including, many on respirators that our family practice residents and faculty were taking care of 24/7. Huge, amazing.
So your school and your system is very fortunate to have the relationship with you and the 3 residency programs, so that the residents and the faculty could come in to staff. I've heard that story in many places, where it was the family practice residents. In fact, I did hear a story in one hospital I won't mention, where the family physicians were teaching pediatricians how to take care of frail elders with COVID. And having family medicine, the Swiss Army knife of medicine, really may have saved some lives.
Yeah, I think that there was a lot going on, and a lot of things that family doctors can be proud of. It showed the amazing adaptability of family medicine people, their commitment to patients. Some of the stories from the inpatient unit. I mean, who were the most comfortable doctors talking to people and talking to family members, and just, it was amazing. And I just have to say that some of the experiences that have been related to me, that went through some of the faculty, as has been described.
So Neil, you're breaking up pretty badly now, so I couldn't hear about those experiences. In fact, you're totally frozen. I don't even know if you can hear me.
We lost in.
So can you hear me?
Yeah, I think we're back.
Yep, we're back. So
Oh,
you
we
were
lost.
about to tell me about some amazing experiences that you heard about in the inpatient setting?
Yeah, I just think that it's amazing that some of the residents have said, or be able to forget, or as they said, to remember some of the experiences that they had. And it's sort of that, these are traumas that the residents went through so early in their career, taking care of people who are dying, covered in PPE, and and just the with patients everywhere. They'd entire hospital in of their main building, that housed like another 100 beds, and that went up in a week. And, but our department cared for 36 patients who were mostly on ventilators. And, and the residents there just, went through it. They went, but the trauma of having experienced what they experienced, I think, are just things that folks are going to live with for a really long time.
So I do worry about the post-traumatic stress disorder.
Yeah.
The impact on so many people. I don't think appreciate. They think a doctor's used to this because they're a doctor after all. But that much trauma, that much suffering, all at one time, that's hard even for the most seasoned practitioner to handle.
And in the face of not knowing whether they were going to get sick themselves or bring sickness home to their families.
Right.
I remember being in my first couple of years as an attending physician at Bronx Lebanon Hospital at the very beginning of the AIDS epidemic, gowning and gloving and putting on all kinds of protection and whatever, and standing at the doorway, not knowing whether, this was going to be the virus that was going to kill off our society, and not knowing enough about how it was transmitted or anything like that. And the terror that we had going from room to room, trying to take care of patients and not knowing whether we were the next ones who were going to get sick, and this was 10 times worse than what we experienced because the numbers were just staggering. We were seeing people one at a time in private rooms, and the pictures, of what was going on in the hospitals, were beyond anything anybody could imagine.
So I want to ask you a little bit about your system. You told me once upon a time that your network of practices, all on Epic, served as a kind of sentinel system for the, I guess, the city government. How did that work out? What role were you able to play?
Yeah, not much. I mean, I will tell you that, this hit so fast and so furiously. I don't think they didn't really need sentinels. The cases were popping up on every street corner and, all through New York City. And it wasn't really about trying to figure out which block it was or anything like that. So but we've always, since those days, and we still work with the city. We have a very close working relationship with the health department. Commissioner Barbeau was really on top of what was going on in the city, as was, the mayor and the governor. And we were in communication with them in relationship to mostly around the questions about testing, which I think have just befuddled everybody. When it seemed like when COVID first hit, we really needed to test people to be able to end the epidemic. But at that time, we didn't even know what we would do if people were positive. We didn't know it was being spread by doorknobs or by, respiratory secretions. I mean, there was so much unknown in the beginning. So I'm not sure. And then when the pandemic really hit, testing was almost useless because, you couldn't really contact trace anybody. Everybody had already been, by the time people were positive, they had already been in communication with 1,000 other people and not wearing masks or whatever, because we didn't really know, what to do. And so now I think testing's really coming back in order for us to sort of normalize our schools, our workplaces and other things. And it seems to be making sense at this point, and it seems to be back being useful. But I think in terms of, our role with the health department or anything like that, I mean, mostly we've been trying to be good soldiers and just taking whatever's coming down in terms of what the health department needs us to be doing. Whether it's testing or catching up on childhood immunizations now that there's kind of a break and we don't know how long it's going to last or whatever it is. Those are the leads that we're sort of taking from them.
So what are the lessons learned for you and for your system?
I think number one, you need a lot of financial reserves. I mean, I was always the kind of CEO that believed that if you had 20 to 30 days cash on hand, that was fine, because the purpose of being a nonprofit was to put your money to use in building new programs. We had 92 active grant programs in our organization now, from foundations and state and local government and federal government and all kinds of stuff. And we do that to build up our portfolio of the kinds of services that we can offer. So a very exquisite diabetes program. We take care of over 3,000 severely developmentally disabled adults, and have developed a little bit of a specialty in that area, where there are needs like that. And so I've always spent most of the money that comes in. And now, when all of a sudden you get hit with something big, you realize, there's a reason why some people try to keep 60 and 90 days cash on hand. So we did fine. It hit us at a time where we had a decent amount of cash reserves, but we're running a $145 million a year operation. So, even if you have $10 million in the bank, it doesn't last very long. So, we were able to, work with our vendors and stuff like that. I think, if there's a couple of messages, one is to just maintain good relationships with everybody that you do business with, and to have an honest working relationship with colleagues and with vendors and with your hospitals and with others, because, none of us are an island. And at the end of the day, our ability to survive and to contribute to society really depends upon the extent to which we can work together as a team with the rest of the healthcare system and people outside the healthcare system. And, if you've done right by people and you've been a good partner for years, I think you can reach out and ask for help when you need it. And people know that you would do the same thing for them. And so we were from that perspective, I'm very proud of our leadership team. They built up a real reputation for sort of coming through on the programs that we commit to and on the grants that we get. And so, we literally had foundations calling us up saying, what do you need? One of them said, tell us what you need, tell me how much money you need. And we sent them a note, and they sent us back twice what we had asked for. Actually that happened to us twice. And then, we've also, I think the other thing that I would say is that we have to really stay with the anti-racism work that developed out of the pandemic. And this is a long-term piece that we just have to be committed to making a part of our everyday life. We started this 20 years ago. We've put out monographs on race in medicine and published on it multiple times. But we weren't really activists in the way to sort of address the problem and try to fix it. And I think we've committed a lot of time now and resources to really understanding what it means at our institute to be an anti-racist organization, and working with our hospital that is now seems to be deeply committed to this. And I'm working very closely with them on their projects, on the things that they're doing, but this is a complete restructuring of almost everything that we do and every way that we look at the work that we do, and I'll just give you a couple of examples. The idea that people come to us and we make them wait in a waiting room, sometimes for an hour, sometimes longer, is such, we think like, wow, we're here, we're doing this great work, we're a community health center, we're out in the community, blah, blah, blah. And, we're heroes in our communities, and we are, but we're also showing people that we don't respect their time, you know, by being inefficient at the things that we do. You know, we get away with things that we wouldn't get away with if we were working on, you know, in a privately insured, you know, mostly white kind of empowered group of patients. And I think we have to be able to improve the way that we work, and be able to show people the same level of respect. And even if they're not demanding it themselves, it's important. We've always done that by building like first class, almost some people say luxurious health facilities. And every time we've opened a practice, but it's how we operate those and our ability to be more efficient and to, you know, really reach a higher level of achievement in terms of quality metrics and stuff like that, that we have to do. And to be able to diversify our staff at all levels, you know, and to be able to commit to training people and to giving them options in terms of career advancement while they're working for us. There's just so many aspects of our organization now that we're really trying to dissect and put back together in different ways. It's going to go on way longer than I'm going to go on. But I think we're really, really committed to this in the long run. And I think that's something the whole healthcare system has to really commit to. We should be a refuge for people in terms of, you know, how we treat people of color in our organizations. And instead, I think, you know, we're part of institutions and stuff like that that still operate multiple classes of care and don't treat everybody the same. So that's our, you know, that's our big nut to crack while we're trying to stay alive financially,
Right.
bring back the
Right.
people on furlough and everything else. So it's just a small, you know, few small tasks that we're struggling with, but
Right.
but we'll get through this and we'll be better on the other side of it.
So I've been talking with Dr. Neil Kalman at the Institute for Family Health in New York City. I'm hoping, Neil, that one of these days I'll be able to get back for a visit. I always enjoyed coming and visiting with your crew. You have a great group of people and 3 fabulous residency programs. I just want to congratulate you on what you've done, and also to really congratulate you on your builder attitude, even in this time when you're struggling financially and it's a lot of stress on everybody. You're still looking at the horizon and building. And I just really want to acknowledge that and say thank you.
Thanks, Lara, and thanks for all the work that you do in keeping us all together and, you know, creating a learning environment so that we're not all struggling with the same things for the first time all the time. You know, we have a consortium that helps us learn together and has done so much to promote family medicine amongst medical students. And it's great. So glad to be here. Thanks for inviting me.